Thank you for joining me today. In this video, we are going to go over mood disorders. Mood disorders include depression and bipolar disorders. Mood disorders are psychiatric disorders characterized by the variation in mood, energy, activity, motivation, behavior that causes a clinical significant distress or functional impairment. They are broad diagnosis divided into depression disorders and bipolar disorders. Some of the depression disorders that are mood disorders include major depression disorder, include persistent depression disorder, premenstrual dysphoria disorders, substance usage disorders, depressive due to other medical conditions. There is a bipolar disorder, type 1 bipolar disorder, type 2 bipolar disorder, themic disorders, substance usage induced disorders, bipolar disorders, bipolar due to other medical causes. And the causes of the mood disorders include major depression disorder and bipolar disorder. Approximately 15 to 20% of the population have depression disorders, and depression disorder is the one of the mood disorders. It's a lifetime, and it is 15 to 20% of the general population develop depression disorders. Women are affected twice as men. Mean age of onset is the early adulthood. Bipolar disorder is a 1 to 3% of the general population. It happens 1 to 3% of the general population, and is equivalent between men and women. So it can happen anyone. Typical onset is late in teens, early adulthood. There is a neurobiological involvement with mood disorders. Mood disorders result from interaction among genetical, neurobiological, endocrine, inflammation, psychosocial factors. Neurotransmitters that involve in mood disorders include decreased serotonin, decreased norepinephrine, altered glutamate signals, and the GABA dysfunction. Brain regions that involve in mood disorders include frontal cortex, amygdala, hippocampus, and interior cingulate cortex. Neuroendocrine changes that causes the mood disorders include the hypothalamus, pituitary, adrenal axis, and elevated cortex level causes the mood disorders. Circadian rhythm disturbance also causes mood disorders. Major depression major depression disorder is the fifth and more 50 and more symptoms that last 2 weeks period, persistent changes from previous function. One symptom must be either a depressed mood or loss of interest and pleasure. So major depression disorder symptoms short term is psychiatric. Psychiatric, if the patient has a major depression disorder, they have to have these symptoms. And these symptoms is short-term, is psychiatric, is sleep disturbance, they have sleep disturbance, interest decreased and sadness, guilty or worthless, low energy, concentration impairment, appetite changes, weight gain. Some of them, they have low appetite, and that lowers the weight. If the appetite increase, it increase the weight. Social motor agitation and retardation, suicidal ideation. Symptoms must cause a clinical significant distress and impairment and not be attributed to the substance usage disorder or other medical causes to be diagnosed a major depression disorder. Persistent depression disorder or dysrhythmia is characterized by the depression mood for most of the day, more days than not. And the duration of the dysthymia or persistent depression disorder is adulthood. It is 2 years. For children and the teenagers, it lasts at least 1 year. Associated symptoms include a poor appetite or overeating, insomnia or hyperinsomnia, low energy, poor concentration, sadness, bipolar disorder. Bipolar disorder requires at least one manic episode. It could be depressed, it could be having other depression disorder, but it has to have a manic disorder, one of the manic episode disorder. That manic episode at least lasts 1 week or any duration of a hospitalization is required. So if the patient has 1 episode of manic and that require hospitalization, either or. So either the manic episode require hospitalization or it lasted 1 week. Symptoms is shortened as dig fast. Manic episode symptoms is the dig fast. Dig fast is the shortened for distractibility, indiscretion or risk-taking, grandiose, fight of ideas, increased activity, decrease for sleep, talkative or pressure talk. Mania causes remarkable impairment, hospitalization, and psychosis. So mania causes remarkable impairment, personal functional impairment, and hospitalization and psychosis. It's hard for the person who has a mania to concentrate, to work, to study, to have a meaningful relationship. So it is impairment and require hospitalization because the risk taking and suicidal ideation, and it's hard for them to sleep. Bipolar 2 disorder requires at least one hypomanic episode and at least one major depression. So it combines two. That is why it's bipolar 2. Bipolar 2, it requires hypomania episode and at least one episode of depression. No history of mania. It don't require any history of mania. Hypomania is at least lasts 4 consequent days. Hypomania. And hypomania is characterized by elevated irritable mood disorder, high increased energy, obstructive change in function, no psychosis, no hallucination, no delusion, no negative symptoms of psychosis like withdrawal or social withdrawal, flat affect, no remarkable impairment, no hospitalization. Hypomanic don't require hospitalization. Cyclothymic is mood swings. It is mood swings. So it has hypomania and depression, hypomania and depression, hypomania and depression, hypomania and depression. It lasts at least 1 year in children and teenagers, and lasts 2 years for adults to be diagnosed with psychothymic. Differential diagnosis of mood disorders and what to rule out. There is a medical condition, there is a substantive conditions that cause mood disorders or that you want to rule out. Mimic is the mood disorders. Medical conditions that differential diagnosis that mimic the mood disorders include hypothyroidism, hypothyroidism mimic the depression, hyperthyroidism mimic the manic episodes. Vitamin B12 deficiency is also a differential diagnosis. Cushing disease is differential diagnosis and mimic. Addison disease is also mimic the mood disorders. Multiple sclerosis or MS is also differential diagnosis. Parkinson's disease, stroke are medical diagnosis that mimic the mood disorders. Substance-induced disorder of a mood disorder include alcohol creates mood disorder, stimulant can create mood disorder. So it's differential diagnosis that you want to rule out first before you diagnose with any mood disorders. corticoid medication can mimic or create mood disorders. Interference medication is isotretinoin can mimic mood disorders and create mood disorders, so it's the differential diagnosis. Other psychiatric disorders that are differential diagnosis include anxiety disorder, schizophrenia, affective disorder, schizophrenia, bipolar, borderline personality disorder, ADHD, grief, reactive. So you want to assist the patient before you diagnose with mood disorder, either depression, major depression disorder, or bipolar disorder. You want to assist the mood symptoms. You want to assist the sleep, frequency, hygiene, and appetite, energy. You want to assess the concentration. So you want to assess psychosis. You want to assess anxiety, and if that anxiety happen, when did that happen? Substance usage disorder, you want to assess if they have any screen, if they have a substance. Functional impairment, how this mood disorder affecting the person functional ability. Medication, if they are taking medication, are they taking complying with their medication? Family history, you want to assess family history. Previous episode of mood disorder is suicidal ideation. You want to assess suicidal ideation risk. Major risk factors of suicidal ideation is the previous attempt. If they have a bipolar disorder, if they have a major depression disorder, if they are sad, if they feel sadness, access to means, recent psychiatric hospitalization, social isolation, protective factors that protect the patient from committing suicidal ideation or taking the next step is the family support. Family support, religious and spiritual, can be protective factors to prevent, or the patient can use coping skills for their belief or their religion. Family support can help the patient to see the end of the channel, and it's protective factor. Future orientation thinking, if they have a goal, when you ask the patient what is stopping you this decision, they will tell you that I wanted my children to graduate, I want to see them to married, I wanted build them house, so the protective factor, future oriented thinking, is the goal that they have in the future. If they have a goal in the future, it's protective factor that prevents the risk. Restricted access to the means. If they don't have means to do, if they are hospitalized, you want to assess the patient. If they are risky to themselves and to others, they have to be hospitalized. Even if they are thinking that and they have episodes of those mood disorders, it's safer to hospitalize and evaluate them there. Lab value that you want to conduct to see if there is any reason other than mood disorders like medical or substance. You have to assess and evaluate the basic labs such as complete blood count, comprehensive metabolic panel, thyroid stimulating hormones, vitamin B to alif, folic acid, sugar, if they have hypoglycemia, can have depression or anxiety. So you want to assist the blood sugar, you want to assist the hemoglobin A1C, you want to assist the lipid, you want to assist a pregnancy test, you want to screen urine drug test. Treatment for depression is the SSRIs. An example of SSRIs include Zoloft, fluoxetine, paroxetine, coletabulum. Of SSRIs include Zoloft, paroxetine, fluoxetine, Lexapro and citalopram. However, these medications have side effects, and some of the side effects of the SSRIs medication are GI upset, sexual dysfunction, insomnia, weight gain, and even though it's rare, is serotonin syndrome. Example of serotonin norepinephrine reuptake inhibitors are venlafaxine, duloxetine, desvenlafaxine. They are used for depression with anxiety, chronic pain syndrome, anxiety, typical depression. Medications include Basbar, Torosodam, typical antipsychiatric, typical antidepressant medication examples include bupropion, metazidine, trazodone, tricycline antidepressant medication. Examples include the amitriptyline, nortriptyline. The limitation is anticholinergic side effects. They also cause blood pressure. They lower the blood pressure, cardiotoxicity, monoamine oxidase inhibitor. Examples include nardate and barnate, and they require a dietary monitoring for thiamine restriction due to the hypertension crisis. So if you take them with monoamine oxidase inhibitor with thiamine food that include thiamine, it can cause the hypertension crisis. So you want to assist that, and it requires diet adjustment. Also, mood stabilizer. Mood stabilizer include the first is the lithium. Lithium is indicated for bipolar disorder. It indicated acute mania and maintenance therapy, and it prevents suicidal ideation. However, you want to monitor blood level of lithium, concentration, renal function, thyroid function, and electrolytes, because this can affect the lithium level. Renal function can affect the lithium level, thyroid function can affect the lithium level, electrolytes can affect the lithium level. Common effects of the lithium include tremors, polyuria, hypothyroidism, weight gain. Toxicity of the lithium, it is the sign of toxicity include vomiting, ataxia, movement, core tremors, confusion. It can lead to confusion and seizure. Fulbrate is the second mood stabilizer, is effective for acute mania and mixed episodes. You want to monitor the liver function, platelet count, and drug concentration level, blood drug concentration level. Lamartine is the second one of the bipolar treatment, and it is the mood stabilizer. It's best for bipolar depression and maintenance treatment. The serious side effect of lamartine is the skin agitation, skin rash, Stephenson-Johnson syndrome, and you can adjust the dose. It requires to adjust the dose and lower the dosage if the patient complain about the rash or skin irritation. Carbamazepine is mood stabilizer, and you want to monitor complete blood count, liver function, and sodium concentration. Those affect the carbamazepine level. SSR antipsychiatric medication is second generation antipsychiatric medication is useful for mania and acute mania and bipolar depression and therapy maintenance and psychosis depression with antidepressants. Psychosis with depression, acute mania, and bipolar. The common second generation antipsychiatric medication that used for this diagnosis include Seroquel to calm the patient, also olanzapine, Lotura, Raspadol. You want to also combine that medication with psychotherapy. Evidence-based psychotherapy include cognitive behavior therapy, interpersonal therapy, behavior activation, family focused therapy, psychoeducation, and didactical behavior therapy for selective patients. Also, somatic treatment that include EKG, electroconvulsion therapy. Electroconvulsion therapy is indicated for severe depression, catatonia, psychiatric depression, treatment-resistant depression, and severe suicidal ideation. That is the EKG. Repetitive transcranial magnetic stimulation is used for treatment-resistant depression. Ketamine is indicated for treatment-resistant depression, major depression disorder with acute suicidal ideation and behavior in conjunction with the comprehensive treatment. However, you want to monitor the patient and you want to assist the after you do all that treatment. You want to do symptom improvement if they are taking their medication, side effects, suicidal ideation, weight gain, blood pressure. Some of the side effects of the psychiatric medication is weight gain and lowers the blood pressure. So you want to monitor the blood pressure, weight, metabolic panel. You want to switch the patient in receiving antipsychotic mood swings. Also, you want to monitor mood swings for the patient who is receiving depression medication. Always screen the patient with depression for history of mania, hypermania before prescribing antidepressant medication, because antidepressant medication can increase the manic episode. Antidepressant medication is monotherapy is contraindicated bipolar 1 because it may precipitate mania or make rapid cycling. So you want to assess any depression before you start monotherapy of antidepressant to a bipolar 1 patient. Lithium has the strongest evidence based for reduction of suicidal ideation in bipolar patients. Lamartine is the most effective for bipolar depression and maintenance, but it is not effective for acute mania. EKG therapy is among the most effective treatment for severe psychotic depression and can be provided rapid improvement. Psychotherapy combined with the medication is generally more effective than either treatment alone for moderate to severe mood disorders. So major depressive disorder takes 2 weeks, and duration of a mania is 1 week. Duration of the hypomania is 4 consecutive days. First line of therapy for major depression disorder is the SSRIs and SNRIs medications. Medication that reduces suicidal ideation in bipolar patient is lithium. Best medication for bipolar depression maintenance is lamartine. Gold standard treatment for severe psychiatric depression is the EKG. Antidepressant mania therapy should be avoided for bipolar 1. Thank you for joining me today. Please prescribe and join me again. Thank you.